So it's a great pleasure for me to give a short presentation on the so-called high-quality hypertension management. Actually, this term was already raised back to 20 years ago because in those years, in the beginning of this century in China, many hypertension patients, they still use short-acting drugs, and they often have low adherence to antihypertensive drug treatment, and they often had not really control of hypertension because those short-acting drugs only lower blood pressure for a short period of time. So in this presentation, I would go through the consensus we reached among experts from several Asian countries. So in this document, we mainly focus on 24-hour blood pressure control with the use of long-acting antihypertensive drugs. And in addition, we also discussed the high-quality management with regard to blood pressure classification and disease severity and mechanisms of blood pressure dysregulation. So you see, we would like to really control blood pressure over the whole day by the use of long-acting antihypertensive drugs. So how we are going to evaluate the treatment effects? So we here proposed the use of blood pressure variability and time in target range. But of course, the primary objective is to prevent cardiac, cerebral, renal, and vascular complications and mortality. So first of all, we should treat blood pressure to the target of clinic blood pressure below 130/80. In our 2024 hypertension guidelines, we propose to treat everybody, almost everybody, younger than 80 years to 130/80 whenever possible and tolerable. And then if a patient has grade 2 or 3 clinic hypertension, then they should start antihypertensive therapy immediately. And for those patients with grade 1 hypertension, so from 140 to 159 over 90 to 99, and they may still have some time for lifestyle interventions, and they may start antihypertensive treatment with both monotherapy and the so-called low-dose combination antihypertensive therapy. So if we start with clinic blood pressure management, so we need to treat to the target. And in Asian countries, we mostly define therapeutic target in two different levels. We should treat everybody to a level below 140/90 if tolerable, and we should treat to 130/80 as we have seen from the previous slide. And probably in the future, we should also treat to a even lower therapeutic target if tolerable and if necessary, because treating to an even lower level probably may provide additional benefit in some patients, for instance, younger patients with albuminuria or chronic kidney disease diagnosed according to reduced glomerular filtration rate. And the key issues for the high-quality management of hypertension is the first to reach 24-hour blood pressure control over and above clinic blood pressure control, as we discussed in the previous slide, either 140/90 in almost all patients with hypertension and 130/80 in many or most of patients with hypertension. And in addition, we should also try to find those patients with morning and nocturnal hypertension, and those patients with abnormal circadian rhythm, because in Asia, we have a quite high prevalence of morning and nocturnal hypertension, also high prevalence of non-dipping sleepers. And that's why we really need standardized 24-hour ambulatory blood pressure monitoring to find those patients and to treat those patients to the controlled level of blood pressure and to the normalized circadian rhythm. And finally, we need to focus on the use of long-acting drugs and to achieve really 24-hour blood pressure control. So why we need to control blood pressure over 24 hours? You see this very elegant Spanish study that showed very clearly nocturnal blood pressure is more closely associated with the risk of cardiovascular events, regardless of you measure systolic or diastolic blood pressure. And for stroke mortality, and you see the same results. You see that nighttime blood pressure is mostly associated with the risk of stroke mortality. And if you look at the risk of uncontrolled morning hypertension, and you see that even such a masked hypertension in the morning, if uncontrolled, they may increase the risk of chronic kidney disease progression. And if you focus another time period in the daytime, so again, at daytime ambulatory blood pressure variability is also associated with increased risk of all-cause mortality. So it means that we should treat the mean level of blood pressure to the target, and in the meantime, we should also treat the fluctuation of variability to a normal level. And why we need to also treat blood pressure variability, because you see it's clear blood pressure variability predicted the risk of events, even in those patients with acute ischemic stroke. And we also look at the elevated 24-hour blood pressure variability as a predictor of chronic kidney disease progression, target organ damage, and the risk of major cardiovascular events. So you see, it's very clear, whenever you have a higher variability in 24-hour reading blood pressure, then you would have a higher risk of chronic kidney disease and higher risk of target organ damage and cardiovascular events. And that's why we really need to control 24-hour blood pressure for both at the mean level and the variability between various readings over 24 hours. So here you see we have listed the target of treatment. We should treat the mean level to the target. We should control morning hypertension, and we should control nocturnal hypertension, and we should reduce variability to a level below 12.8 millimeter mercury of weighted standard deviation of systolic blood pressure. So here we also provided the therapeutic target for all these parameters, So the 24-hour mean systolic and diastolic blood pressure should be below 130/80, and daytime below 135/85, and nighttime below 120/70, morning below 135/85, and for weighted standard deviation of systolic blood pressure below 12.8 millimeter of mercury. So how we are going to achieve these various and sometimes difficult targets? So first of all, we need to focus on the risks of cardiovascular, cerebrovascular, and renal risks. So that's the primary objective of blood pressure lowering and management of hypertension. So then we should perform home blood pressure monitoring routinely, and to achieve a really long-term blood pressure monitoring and management, and we should compute long-term blood pressure variability and time in targeted range as predictors of cardiovascular risk. So we should also try to utilize any technology, for instance, digital technology and artificial intelligence, to help us record all the blood pressure measurements during a long period of time, then to really achieve blood pressure control over a longer period of time. And we have a lot of evidence on the risks of higher visit-to-visit systolic blood pressure variability, mostly from the very famous ASCOT and ASCOT extension or ASCOT legacy studies. So you see in this slide on the left hand, clinic systolic visit-to-visit variability was significantly associated with all-cause mortality. On the right hand, also associated with the risk of strokes. So it means that regardless of the studies included in this meta-analysis, you see a very consistent results on the risks of blood pressure variability with regard to the risk of mortality and fetal and non-fatal stroke. Several previous studies also showed that long-term visit-to-visit blood pressure variability was indeed also associated with development and progression of chronic kidney disease. So it is a very busy slide, but the message is very clear. If you have increased blood pressure variability, you would have a higher risk of kidney damage. That's also why we need to define cutoffs for long-term blood pressure variability. It is a very controversial field. Even after many rounds of discussions among all of us, we have not yet reached a consensus on two major issues. First is whether we should use standard deviation or coefficient of variation, and the other is the level of this cutoff for the definition of increased long-term visit-to-visit variability. But for the time being, we try to reach consensus. We probably should use two of them, standard deviation and coefficient of variation, by standardization for the mean level of blood pressure. So here we still have to work very hard to find the best solution for the control of blood pressure variability. And we also have another choice of evaluations on blood pressure control. That's the so-called time in time in target range. So here you see already several studies showed the association between this new index and the risks of events. So you see on the left hand, that's all cardiovascular events. On the right hand, that's fatal and non-fatal stroke. So all these events can be related to the new parameter time in target range. So whenever you control blood pressure better with a higher time in target range, you would have a lower risk of events, cardiovascular events and strokes. The kidneys, we have seen a lot of data on the risk of kidney damage. Here again, TTR was also associated with the risk of adverse renal events. You see, it's not linear, but the trend is very clear. Whenever you have a higher TTR, you would have a lower risk of renal events. So how we are going to calculate this new index time in target range? So there are several different approaches. So according to blood pressure measurement, you may calculate for clinic blood pressure across a longer period of time. You may also calculate this index according to home blood pressure measurements. You can even calculate this index using 24-hour ambulatory blood pressure monitoring. We recently published data in the European Heart Journal that also showed a very clear message. This new TTR index can be a very important predictor of blood pressure control and eventually the risk of cardiovascular events. So finally, among the experts from Asian countries, we reached a consensus and proposed recommendations on the so-called high-quality hypertension management. So we listed these 6 major points. Actually, I have discussed almost all these issues. So it means that we should treat hypertension, not only the mean level, but also the variability, and over a longer period of time as higher as possible. And finally, I would bring 2 major messages. So first, we propose this concept of high-quality hypertension management to improve the management of hypertension in Asian countries, especially according to both blood pressure and other measurements, for instance, disease severity of target organ damage and mechanisms of blood pressure dysregulation. And the other major issue is how we are going to achieve this high-quality management. We should evaluate 24-hour blood pressure control, and we should also evaluate blood pressure variability and time in target range to really improve the management of hypertension and to prevent cardiovascular events. Thank you. Thank you very much.